I will start recording the session now. Hey, the floor is yours. And you're mute.
Hi, sorry. I should have practiced sharing this slideshow, but I hope it's about to work. Or maybe it's not. Sorry, Roberto. Just hit share screen to...
Yep, at the bottom part of Zoom, you have a tiny icon that says share screen. If you click in there, then you will have the menu in which you actually can select your screen to be shared.
Oh, it wants me to quit. I'm so sorry. I was supposed to come early to do this and I was late. It's going to make me log off and log back on.
Okay, what we could do, if it's helpful, in the meantime, if Matt doesn't mind starting first, you can send me by email the presentation and I can share it for you. Would that work for everybody? Awesome.
I can send it to you. I think it will let me share once I close this. I'm sorry.
Okay, no worries.
Awesome.
Then we will go with Matt first. Thanks, Matt.
Hey everybody, my name is Matt Southwell. I'm the project executive for EuroInput, which is the European network of people who use drugs. Just to be clear, I've not been homeless myself, so I am someone who is a drug user, but I've not been a homeless person, and I just want to be transparent in terms of the expertise I'm bringing to this meeting. I did run through the 1990s a homeless organisation called a drugs organisation called the Healthy Options Team, or HOT. And that was an agency run by NHS, half NHS professionals and half drug users. And we worked together particularly to engage drug users at risk from HIV, but particularly to target people who were also homeless. So let me draw on that experience, plus also my experience of working more locally as a drug user activist through the COVID pandemic, and draw some reflections from those two experiences. So firstly, why do I think that peer-led harm reduction and meaningful participation are important issues for people who are both homeless and also using drugs? I want to recognise that when you're living homeless in its multiple forms, it can be harder to make informed choices just because you have more restricted resources and more restricted environments within which you're taking drugs. However, I think it's important to recognise that people who are homeless have their own peer support structures, and those are often very significant in terms of people surviving and helping each other on the streets or in other forms of homelessness. Importantly, when we're trying to reach homeless people, one of the things that we can understand is that one of the stable structures that they might have in their life might actually be their drug supply and drug using system. So the fact that they may be moving around and engaging in and sleeping in different places, actually they may be using a consistent number of drug suppliers, and if those drug suppliers are tied into a peer-led harm reduction scheme, then that can provide a point of connection. I think the other important thing to remember is that homeless people are not always operating to the same time standards as everybody else. I remember waking up early last week to have my first peer call for an NSP, a needle and syringe program, at 7:30 in the morning. Now, I think we often think people who use drugs aren't up at that time, but people who are homeless are often being forced out into the streets, particularly if they're in hostel accommodation or sleeping in doorways. And we need to think of the times when people are wanting to access services. So to draw back on the lessons of the Healthy Options team, this is the logo in the left-hand corner. Sorry, it's a terrible version, but it shows we don't really have very much photo record from that period. The Healthy Options team was a team that was formed by people who used drugs as part of the National Health Service in the UK during the 80s and 90s. It was a model that really tried to reinvent drug services by really putting community mobilisation and meaningful participation really at the heart of the model. The first thing we looked at was trying to create a low threshold service model, which was how can we make the service as accessible to people as possible. One of the questions we asked was, is it that people who use drugs and the homeless are hard to reach, or is it just that our services are very inaccessible and not well designed for people who are homeless? So I think we started to question, what could we do to make our services low threshold, rather than assuming that the population was hard to reach? And in many ways, we saw the homeless and most marginalised as like the canaries in the mine, or the test of our system, to see, you know, if they can't make it in, then our service isn't accessible enough. A key point of access was how we got people to come into our services. So local drug suppliers made up 80% of our local referrals, and that was absolutely critical. I had one local woman drug supplier was our biggest referrer to our service, and she said, look, when people come to me and sell me their children's clothing, I respond as a drug using mother, not as a drug supplier. And at that point, I want to refer people and help people to access the help that she knew was available in a non-judgmental way. When we think about peer-led harm reduction, we need to think about how we can get harm reduction services to people living in very informal or unstructured environments. So for example, the Healthy Options team, we had a very large and problematic homeless squat in East London called Tower House. It was a big old council building that had been developed. It was very unsafe to travel into. We decided our outreach workers couldn't travel into the building because it was just too dangerous. However, we made arrangements with drug users living in that building that we would leave needles and syringes by the door, and they would leave the bins of the used syringes ready for us to pick up. And while we couldn't go into that space, by mediating that space with the drug users who were living there, we were able to get needles and syringes into a setting that we weren't able to work in, but that peers were living in and could mediate with comfort in their own spaces. I think we also needed to think about how we provided methadone and buprenorphine, opiate substitution therapy. Often we found that homeless people couldn't make it through the structures that we set up that were designed to say, are people stable enough to access OST? But that seems a bit illogical. If people's lives are really unstructured and unstable, then we should be making those services really accessible. So we did opiate substitution therapy through our service. We did it with local GPs. So we used community doctors because we felt that gave drug users who are homeless access to a whole range of primary care services as well as OST. The condition of their engagement was that people had to come to our drop-in centre once in a fortnight to pick up a voucher. And as long as they came once in a fortnight, showed that voucher and could show that voucher to the doctor, then the doctor would issue the next prescription. In fact, many people came 3-4 times a week, but by making the threshold low, people could choose to engage in extra services rather than the service engagement becoming a condition that then became an effective barrier to access. We also had excellent mental health nurses. We had a series of mental health nurses, but Peter Phillips was one of our research nurses who went on to be a researcher, and he did some really interesting work looking at mental health and homelessness. And he started to challenge some of the assumptions, because we were often assessing homeless people, say like a homeless schizophrenic versus someone who was homeless living with, I don't know, anxiety issues, but we would compare them with other people who were living in house situations. So when we compared people with other people who are homeless or people who had schizophrenia but weren't homeless, then we could start to see people's use of drugs in a more functional way, that actually sometimes people were managing their mental health through their drug use or managing challenges of being homeless through their drug taking. So to always see drug use as negative and non-functional didn't allow us to have a healthy conversation with people about these drugs may be helping you survive in these contexts. How can we help you use them in a safer and more sustained way in that process? Interestingly, we also had one of the very early examples of drug consumption rooms in the UK. Our nurse allowed drug users who are homeless to come and inject their injectable prescriptions in our medical room. Now, it was a very restricted service just for people who were prescribed injectable drugs, but it really highlighted a need that is really clearly identified, that street injecting is a very high-risk behaviour that can easily be addressed with drug consumption rooms. One last thing I think is just to highlight the role of the drug using community in staying in touch with people. we found the sort of traditional confidentiality models didn't really work in this population, because actually people looked out for each other. When we lost touch with someone for a while, was it because they'd moved away? Was it because they'd died? Was it because they were in hospital and needed help? Was it because they were in a psychiatric hospital? What was happening to make sure this person had dropped out? Sometimes it was really good news. They'd gone on holiday or moved on or something. But by talking to peers and creating that sense of peer connection, we looked out for each other as a community. And traditional confidentiality models, I think, shocked some of our partners, because people didn't quite understand why we had this conversation about each other. But it was like a community looking out for each other, not a breaching of confidentiality. And of course, that needs to be consented and carefully managed. So just here to stress, peer-led harm reduction is key because it works through drug supply environments. Drug users have privileged access to supply networks, to marginalised communities, and to the structures we use as communities, and we are trusted by our peers. So we can take knowledge and services out to our community in a way that others can't. One key service that we're increasingly taking out is this drug called NALOXONE. This comes in 3 different forms: a simple glass ampule, a nasal version, or a pre-filled syringe. And NALOXONE effectively, when you have too many opiates in your brain, it stops your lungs from breathing, and that means you overdose and die. Now, naloxone comes in and pushes the opiates out of your brains for 20 minutes, and that gives a chance for the opiates to peak and for the overdose risk to pass by. Now, there's different ways that you can distribute naloxone, either through emergency services or traditional drug services. But increasingly, we're recognizing this model called peer-to-peer naloxone is very, very effective at getting naloxone into the hands of non-service users, those people who are not in touch with traditional services and actually at the greatest risk of overdose. So, just finally, to draw out some lessons from our experience. So I work in a drug user group called West Country Respect in the west of England, and we run a secondary needle and syringe program pilot, which basically means a peer-led needle and syringe program. We have about 700 needles and syringes being given out a week by local drug suppliers, and we are the first area in the UK to hit 100% NSP coverage. Most areas are achieving about 30% coverage, and that's coverage with quite a wide array of different needles and syringes, plus peer-to-peer naloxone. And the key of this model is that we've also been able to actually have in the local hostels that have been open during the COVID pandemic, we've got peers in that hostel who are receiving needles and syringes. So one of the rooms in the hostel, everybody understands that the drug user in there has a stock of needles and syringes. It's not officially recognised, but it's not officially objected to. I hope we can move to a more recognised model in time, but to start with, it's at least a practical peer-led response. Take-home doses have been absolutely critical to the change. We've had new people coming into treatment because of COVID, some people who couldn't access because of disability or because of agoraphobia, other issues. People are now making it in. Changing the way that hostels work so that rather than making opiate substitution therapy a condition of accessing hostels, we support people to access OST so they can get into hostels. It's a different mindset, and it actually puts us as the workers behind the drug users and the drug user groups behind the drug users, getting them into services rather than sitting there saying, until you meet these conditions, we won't respond to you, which just seems really unhelpful as a way of working. And I think COVID has really positively changed that mindset. What we've also been advising on, and I'm really happy to have been talking to some Scottish providers about this, is homeless providers now recognising that we need to respond to active drug users in hostel and supported housing settings. We can't say, when you have stopped injecting drugs, when you've stopped using drugs, then you can access housing and hostel support. Increasingly, we've seen in Belfast really good hostels specifically set up, understanding that people can access needles and syringes, understanding that if you overdose, you don't have to hide it, you can seek support from staff, and generally that things are no longer hidden and secret, but they're actually supported and engaged. One hospital in London, we heard of drug users not being able to use the local NSP because if they did, then the staff would find out in the hostel and then they could lose their hostel place. Now that's the worst type of joined up service, when we're actually joining up stigma rather than joining up help. What I'm really pleased to see is that there are more services now recognising that we need to make this currently minority practice of wet houses and active using houses something that becomes much more mainstream. And just to end, really reflecting on a woman locally who I've been working with as a local peer, her life has transformed since COVID. I mean, she has been living with chest problems for a long time, living homeless on the street as someone who was a migrant who couldn't get into mainstream services. Since COVID, she's been housed, she's got onto OST, she's had her lung health is dramatically improved, and she's now being supported to access a range of services. So rather than her active drug use, her migrant status, all being seen as reasons to exclude her from services, key workers have come alongside her and said, how can we help you? How can we support you to engage? And I think that is a key shift in the way that services are running. And a last mention is just that one of the things we've learned is that drug consumption rooms are a key missing component of the response. Glasgow has had an HIV outbreak. In 2015, I first started working on HIV back in the mid-1980s. It's a disgrace that in the 2015 we had another HIV outbreak in the UK. Absolutely a correlation between street injecting and the arrival of cocaine and rapid repeated patterns of injecting and street drug use. That led to a terrible situation that the government wants to respond to in Scotland, but is currently being blocked by the Westminster government. And Peter Cryant is an amazing activist in Glasgow who has just set up a drug consumption room in a minibus to challenge the law. And I think this type of radical harm reduction is the future. Thank you for your attention.
Wonderful. Thank you so much, Matt. I wonder if there is maybe like one or two questions that anybody has like urgent at the moment before later on we open more of a bigger discussion. Anybody can bring it to the front.
Yeah, I don't have a question. I just wanted to say that I really liked your presentation. I'm from Portugal, and sometimes when I'm present in these type of meetings and sessions, I feel like I'm in a parallel universe because we are seen as such a good country for drug users, but then we have nothing of this. We have some good services in Lisbon and Porto, but that is it. So the place where I'm working right now, we don't even have low threshold OST. It does not exist at all. People have to go through a very complex system if they only want methadone, and they don't decide if they want methadone. It's decided by the doctors and technicians, and I just wanted to say congratulations and keep up the good work. Yeah.
Thank you, Teresa. And my treasurer is from Portugal, from the drug user group CASO, based in Porto.
Yes, I know them, of course. Yes.
So yeah, look, and one of the examples of peer-led harm reduction that's been really key has been CASO's work in some very informal settings. And we're really pleased that they're currently bidding to do some work to expand their network, because currently they're just based in Porto and Lisbon. And as in many contexts, we want this then to spread to other settings so that other people can benefit from this engagement. Thanks, Teresa.
I'd kind of like to say as well, similarly, like we have some of the same blocks in Ireland, like where you're saying that you have a service user who needs to be on an OST program and wants to be on it, or wants to be linking in around alcohol abuse, but they're kind of given an appointment time, the same appointment time, and they're not making it. And it's like, oh, we're gauging their motivation. But there's like, if you're kind of constantly seeing that they're not making it, is there a way around it? Is there a way of, like going to them or something that would help get the person linked in? Surely that's everyone's goal. So it can be so frustrating, like for us, like as workers.
Yeah, Christine, I think that's really important. I think one of the things we need to recognize is that opiate substitution therapy gives people stability.
Yeah.
It shouldn't be a condition that you find stability before going into OST. That's the wrong way round. So then how do we as homeless services reach people to engage them in OST, so then we can engage them in the benefits that come from that stability? Well, I think we should be going to them, not the other way round. Let's go and do assessments on the street. Let's take doctors out, assess people, give them a prescription on the street, and do it there and then do the psychological and social assessments afterwards. There is a new drug called long-acting depo-buprenorphine, which is a new version, and it's a drug that lasts for maybe 1 week to 1 month as an implant. We thought this would be a drug exclusively useful for people that were very experienced with buprenorphine and then wanted to use it after they'd used sublingual for a while. However, in King's Cross in Sydney, they are showing that using depo-buprenorphine with people who have very unstructured lives could actually engage them in services. They should always be tested to make sure they don't have any negative reactions to the drug first, but then potentially giving them a drug that lasts for a week, so then they're not withdrawing for a whole week, and they also can't take opiates because they won't then have an effect. If it's the right drug for the right person and they're choosing that, that's a new strategy that could help people access services if they're not stable enough to take a daily dose.
That sounds amazing.
So it's called Buvidal. I think the version in Ireland is going to be called Buvidal. Yeah, in Europe, right? Or long-acting depo-buprenorphine.
Is there any other question or comment or experience sharing that anybody want to bring forward before we jump into the next presentation? Then we'll go to you, Tate.
Okay, thank you. Thank you, Matt. Let me see if I can make this happen now. That's working, yes?
Yeah, perfectly.
Okay. So hi, everybody. I'm Tate. I'm super happy to be here. I'm also going to talk about peer-to-peer harm reduction, but from this idea of harm reduction from below. So there's a lot of similarities, but some differences too, although I'd say, like Matt, what I'd like to think about is ways of opening up different mindsets more than anything, which of course can lead to different practices and services. So I'm sort of an academic, but more importantly for this, I'm a former nightlife worker in Brooklyn, where I worked in nightlife for a long time until I got involved in a project called Chemical Youth. And through that project, I looked at how nightlife workers use drugs as part of their work. And so I also want to draw a connection there to what Matt was saying about using drugs to manage things like mental health and homelessness. This started to change how I was thinking about harm reduction because drug use became something valuable as opposed to something inherently harmful through this project. So today I wanted to think a little bit and build on the current enthusiasm for peer engagement in harm reduction programs. But instead of asking about how to involve or engage peers in services that already exist, what kinds of practices are peer groups of people who use drugs already engaged in? And so by practices here, I'm talking about something a little bit less official, maybe, than like peer-led harm reduction services. So this is what this project I'm a part of called Chemical Youth calls harm reduction from below. Basically, how are people already taking care of each other in their groups of friends and peers? And the first thing that you notice when you look at this, of course, is that people who use drugs are often as or more concerned with encouraging pleasure and care as with mitigating risk and harm. And so I kind of want to take that seriously and ask what that means for harm reduction if we start there. And so I think you have already all talked about harm reduction this week, and I'm not going to review it too much, but of course, harm reduction has always been about peers. And again, Matt gave us a really nice, some history of how, of needle exchanges and HIV harm reduction practices that were by people who use drugs, for people who use drugs. And what harm in these kind of early harm reduction practices, one of the most interesting things was that they raised the question of what is harm. And then as harm reduction becomes more institutionalized, this question gets answered in different ways. And so when harm reduction becomes something that needs to be evaluated, what we're actually talking about is what matters. And so again, instead of thinking about evaluations, I'd like to think about different ways of listening, about different ways of hearing, and about different ways of being in terms of thinking about whether or not our harm reduction practices and services are working. So while most peer involvement today is things like peer education, peer counseling, peer research, and peer networks, all of which I think is great. Again, like I said, I want to ask what about peer groups or how are peer groups already caring for each other as opposed to peer workers going into communities and working with an organization. So I apologize for the quote, but I was struggling to finish this at the last minute because I lost access to my former version. But from Chemical Youth, this is some of the conclusions that we came up with, which is that we tried to focus not only on users' concerns, but also how these concerns shape their approach to drugs, what young people do to navigate uncertainties, and how they reach out and create different sources of knowledge to minimize adversities and to improve highs. Harm reduction from below, we argue, can best be seen in the practices of sharing around drug use and in the caring for the larger community of drug-using peers. And I think it's important here also to mention that much of this research was done in nightlife. So of course, there's going to be a lot of important distinctions with something like injecting drug use on the street or homelessness in terms of yeah, just in terms of the concerns of drug users and also the way that that kind of drug use is seen by medical professionals, society generally, and perhaps the people themselves. So of course, it's a bit easier looking at nightlife to start from these ideas of care and pleasure. And just like nightlife harm reduction, something like Unity in Amsterdam borrowed from older harm reduction with injecting drug users. For example, Unity passes out clean straws to snort with, which of course it comes from the idea of clean syringes. So nightlife harm reduction has learned from these other kinds of harm reduction. And the question I have also is there something nightlife harm reduction can also teach, or another way for that conversation to be two-sided? As you can see, I have mostly questions, not a lot of answers. But here are some things that we came up with through our research with peer groups. And this was just kind of ethnographic research, basically, to put it casually, hanging out, deep hanging out. But so what we pulled out in terms of harm reduction for below is that there's certain kinds of work that goes into informing these harm reduction practices and making them possible. So things like handling and sharing of drugs to facilitate hassle-free highs, creating pleasant and friendly spaces, and seeking and sharing of information and practices to spread the good high. These are super basic things. In fact, most people would say there's no reason to even point these out. Of course, people are sharing their drugs or sharing information. But so what we do in this project is try to really pay attention and ask what it would mean to support these practices themselves. And I'm talking about, here I have an image, really some things that seem common sense, but as we get to the end, I'd like to suggest they're good to think with still. So in this image, one of our researchers was working with groups of people who throw after parties and do a lot of GHB. And one of the things that happens is there's someone at these after parties who keeps this diary that you can see this image of that was anonymized and published. So it's okay here. Of the different dosages and timings. It's not like a spreadsheet, it's someone's notebook, but there is a certain kind of order to it and a care that went into ensuring that everybody at the after party is not overdosing on G, that someone is aware of the times that they're taking it, just basically caring for each other. And so that's one example. And in general, we noticed a lot of things like controlling for quality in terms of, again, between peers, cautious dosing. So this can be things like the GHB where someone is in charge of dosing and making sure that everybody stays safe. Tuning spaces and moods, again, just very basic ways of caring for each other in the body, in space together. Balancing acts, like how much to sleep if you have to work the next day, or how much you need to take in order to work. And online support is also something that Chemical Youth has been really interested in. And I think is actually really interesting for harm reduction. So websites like Arrowid, where people post trip reports, different kind of experiences, mixing drugs, their doses, these kinds of informal, but increasingly formalized networks and repositories of knowledge that again are by the community and for the community. And now it's just text, but only 2 slides. So yeah, in general, when we talk about alcohol and other drugs, these kinds of discourses, whether it's in academia, often in professional fields, certainly in medicine, exclude any consideration of pleasure, instead centering questions of risk, harm, and health. And so whether this happens kind of through an older frame of individual pathology or addiction, or a concern with context in research, things like socioeconomic structures, even in both cases, pleasure often appears as a side effect of drug use, not the main reason people are doing it, and certainly not as something valuable to people who use drugs themselves. And I'd like to suggest that this has to do with the idea that risk, harm, and health are seen as something that can be rationalized, quantified, and measured. And so then, whether it's evaluating harm reduction or just looking at people's practices, the concern becomes about good measurements and not good feelings. And so in terms of caring for pleasure, this would be a kind of goodness where the good is established in caring practices, not in theory or measurement. So again, that the notebook is a very simple kind of mundane example of a good harm reduction practice happens when the notebook allows people at the party to pleasurably enjoy their drug experiences together. And again, this is of course all going to be different for different kinds of drug use that maybe isn't in nightlife or not at a private home. And so just to kind of wrap up in terms of these ideas I've thrown out here at you, but the emergence of harm reduction from within communities themselves historically, and also the growing enthusiasm for peer engagement right now in harm reduction organizations, I think should suggest to us and encourage us to think about the ways that people who use drugs can and do care for each other. But caring between peers is often only legible to states, professionals, researchers, and institutions as effective care, as meaningful harm reduction, when it aligns with normative notions of harm and health. So these are the kinds of ways that medical professionals think about these things. But even just the idea that drug use is itself inherently harmful and that needs to be mitigated. With Chemical Youth and the idea of harm reduction from below, the question that we ask ourselves, and I would suggest is not a different way to do harm reduction, not a better way, but maybe just a different mindset to adopt that can certainly pair with other ways of thinking and practicing harm reduction, is how do peers already care for each other on their own terms? What are these terms of health and care? Or as I'd like to suggest, perhaps actually care and pleasure come before risk and harm. And what might a harm reduction look like that actually starts with the idea that the reduction of harm is the maximization of pleasure? Yeah. So sorry that was a little scattered, but I very much look forward to talking with people later, and am glad that PowerPoint is done.
Thank you so much, Tate. Is there maybe any questions, any comments that anybody would like to bring at this point?
I can come again. I just wanted to say that I find it very interesting what you said about the omission of the pleasure, because we always talk about harm reduction, and we forget that we also have to focus in maximizing the pleasure, because no one does drugs because they are bad. Everyone does them because they are good. So reducing the harm is also maximizing the pleasure. And I think that especially in nightlife settings, I think that that's a very important message to pass through. Just a comment.
Yeah, definitely. I'm glad that that's exactly the kind of thought line I'd like to go down. And just to add, in my own research, I was working with people who work in nightlife, not party goers. And that also starts to complicate the idea that harm and pleasure are opposites, that productivity and pleasure are opposites. I found people needing to do cocaine, to bartend. They couldn't get paid unless they were doing drugs. It becomes a very, when you start really in the community itself, these notions become very complicated. And then the question of what's good stops being something that someone from the outside can define. And we have to ask what is good for these people themselves, even if it may not look good, like doing a bunch of cocaine to bartend. Thank you for your comment.
Beautiful, thank you so much. So if there is not any questions, any other comments? Also,
Roberto, just say one thing, Tate. I think it was a really fascinating discussion, because I think the World Drugs Report from UNODC talks about how 90% of people who use drugs do so non-problematically, while 10% do so problematically, or have more challenges with their drug taking. Having been in both groups, I think what I notice in both populations is this commonality of people caring for each other. Among the 10%, there might be more challenges of rip-offs and things like this at times, and they occur in both groups. But the dominant interaction with peers is people caring for each other and looking out for each other. And I really recognise what you're describing. Yeah. We had a group called the Dance Drugs Alliance, which had a slogan called "Maximum Pleasure, Minimum Risk." As I asked that right.
I think it's great that if you start by looking at care, that kind of problematic and not problematic distinction goes away as well, right? And now we don't begin with that, and all kinds of maybe new solidarities and services open up. Yeah, thank you.
Yeah,
I want to say something. I work with people who are homeless for at least 3 months, and I see that there is not such a peer group as you talk about it, that they look for each other. Mostly the people I work with are alone, and if they have friends, if they can stab them in the back, they will, for their own good. So I can recognize some things you say, but more as a drug user who uses drugs for pleasure, and not in when they just use drugs because they cannot see another way, and they're so addicted that that's the only way that they can see. So
yeah, I thank you for sharing that, and I think it's really important, and it's why I didn't want to say that this is a different or better way to do harm reduction, but a kind of mindset that we can slip into and out of. So we could think of something like, in this case, instead of focusing maybe on the drug use that that the people that you work with are doing, what kinds of situations might we be able to create that would allow them to create caring networks of their own? So instead of immediate, I'm not saying that you need to do this or figure it out, but in terms of thinking of other ways of harm reduction, instead of saying, let's reduce their drug use or they don't use drugs for pleasure, what kinds of situations might we be able to create institutionally or radically politically on the streets in various ways to allow for caring networks to open? And that could be, of course, shelters or free housing for everybody. Right? Obviously, I'm not afraid of the utopian. I think we also should keep that in mind and not give up on that while staying real to the gritty reality of most people's lives. But yeah, obviously, nightlife research can't inform what exactly would happen in homelessness.
I think it's also about saying that I know as a hard drug user organizer, I mean, a lazy term, hard drugs, but I have to work with peers who rip me off at times. And some people I've organized with have also ripped me off. And then we come back together again, and it's embarrassing, and you have to find ways past it to recognize that, yeah, okay, this is part of the life. Sometimes people rip each other off. We can still work together and care for each other at other times. And there are some people in the community who are just rip-offing all the time, and they become very frustrating to be around, and solidarity can be very hard in those types of moments. We had one guy robbing people in our scene all the time, and part of the community was, how did we manage this situation of someone who is in a criminalized community, so you can't call the police, he's robbing all his peers. And as a community, it really disrupted our peer-led network. It really disrupted our ability to come together. And it only resolved when the guy died, in fact. But no, these are realities. And I'm not trying to say that this doesn't go on in our community. It does. And also a lot of care does as well. And it's how do you mediate those two things at the same time, I think, is part of the challenge of the work in the hard end of the community. Isn't it?
That's a really interesting experience that you mentioned there in terms of that. So the context of the place where I'm working in is a youth service working with young people who use drugs. And within the context of that, we've had a quite similar experience as well in terms of this concept of friendships born of a shared trauma, a shared situation. And within the group itself, it was quite interesting to see that that piece was going in there, but the group itself was able to manage and able to police itself insofar as identifying that even though there are these maybe challenging behaviors amongst the peer group, they were able to bring it back to a space of solidarity of going, look, we're going to moderate this behavior amongst ourselves. That's not necessarily the language that was used in the space, but we're moderating this space for ourselves because we're all sharing the same pain and same trauma, and we ultimately are going to remain peers. So how do we negotiate this space? So there was that little piece of transferability around the peer care where even through difficult times and, as I said, ripping each other off, to use that phrase, there was still that space of going, but we will look out for each other and we will flag if this person needs help and we'll signpost to other services. So it was this interesting line where maybe a normative standard of what care looks like wasn't necessarily applicable in the youth homelessness sector, but at the same time, there was this core element of care and solidarity in it.
Yeah, that's a great point also on it's not just about normative notions of harm and risk, but also normative notions of care and questioning those, of course. Anybody who's been or especially worked in a queer community knows all about navigating both getting ripped off and feeling a sense of shared solidarity. Also often a lot of drugs involved. So I think lots of us are navigating that also, and we shouldn't, again, only put it on these communities as well. Yeah.
Beautiful. Keep it a bit, I'll be the one that actually has to keep it a bit time on mine because we have 2 presentations more. So if there is more things, keep them, we'll bring them a tiny bit later or add them because this is complexifying the discussion in a beautiful way. So I would like to give the floor now to Hendrik, which is going to be presenting a tiny bit of a case study from a different angle. Hendrik, all yours.
Thank you. It should be there. So what I'm going to, my perspective is that our team was initially started from the street. It was people going into the street. It was healthcare workers going in and out of different institutions and actually interacting very closely with people in the street and taking drugs as part of their life. And it was always a basic thing in our healthcare work that people do drugs and do drink, and they sometimes want to stop it, but that's not it's not necessary for us to actually engage in that to give healthcare. So I'm going to give you at least 3 examples, and then predict a little about a project that will come in the next year. The first thing we did when the first example I can give is development of a NALOXONE training project, which was actually initiated by the Danish Drug Users Union and their chairman, Jørgen Kjær, who for years lobbied for us to start out doing naloxone training in Copenhagen. And we started out and did that as a small pilot project in 2010. And the supervisory board for that was including Jürgen Kjær, and actually he became the first layperson naloxone trainer. And his users union has continued to use naloxone and training naloxone for their activists in the 10 years we've had this project. And they have saved more than, or they have reversed more than 70 overdoses in their facility over the 10 years. So they also were very close in developing the kit. It was a bit clunky, but we only had these ampules and syringes, so we had a lot of stuff in that kit from the beginning. But it worked out, and a lot of overdoses was reversed in that year with a very small group. So here's Jürgen preparing to do the naloxone training in the Drug Users Union. I was with him as the MD and as the doctor, and he was training his peers to give naloxone and provide overdose reversal for the group. And we did. Over the years, we have used also the Scottish pranoxate with a nasal spray fitted onto it, and used that in the Drug Users Association. And another picture from there. And Jürgen was co-author of the first report on that. Another small one. It was actually. It only lasted 3 months, but it was a very good experience because we were thinking that with the rising use of crack cocaine in Copenhagen, we could see people transmitting hepatitis C via the pipes. So we wanted to get the pipes. To develop CRACKPIPE kits for the users. So we had an initial 3-month consumer survey where people got. I can show it here. We had a kit we actually took over from Vancouver, and it had 17 items in it, and we started out with that, and then had people tell us what to take away, and you know, in 3 months we had this small since, and actually we never have had any problems with the waste in the streets from that, because people only get what they need. Another good thing from that was that the kits were assembled by the Drug Users Union, and it was paid for by the city, so they were paid by the hour for doing the work. So this small project actually gave work to the Drug Users Union for several years after that. So they have they both went into the development, got the first kit from Vancouver, and then afterwards supplied us with the kits to give out. Yeah. The third one is still going on. It started out as well, we found each other in the street, you could say. We knew about each other's existence, and we came from two sides looking for transmissible diseases, and were looking especially the Drug Users the Users Academy was looking for hepatitis C in especially for that, and we have over the years 2 to 3 times per year been connecting with institutions in the homelessness area, and we have have done public health screening at different sites. So the first thing we did was actually to connect with the drug, with the Users Academy, and at a football arrangement for homeless people. And the Users Academy was doing hepatitis C screening, and we were making naloxone training on that site with people who were actually playing football that day. It was a good experience. We didn't do much in training, but we had a lot of talk, and especially we recognized each other at that event, and it actually led to doing something more intensive. So we have done several events since then, where we go to local shelters, we go to local, this is the night shelter at Sundholm, where we have our office, and this is the Drug Users Academy's, the Users Academy's bus where they have a FibroScan. They can test for hepatitis C. And we do the Save Life naloxone training just beside the bus, and inside the health team is taking blood samples and doing healthcare screens. So it's all going on at the same time, and the night shelter was we paid for some lunches there, so people would stay and they could have free lunch that day. So this is the last one is from Christiania. It's a small video, so there's some music to it, but I'll just let it play. It gives a sense of the how it was that day. So it actually worked. We're still doing this. We have unfortunately been cut down by the Corona lockdown, but we will next week, when we have testing week, we will do two times outreach, one in Sundholm and one at the Safe Injection Room in Copenhagen. The last one is just beginning. And Marie is part of this session, so if you have questions for her, you can ask. But we're trying to do a community reinforcement approach, work with people in our social employment, and we have just asked SAND, the homelessness organization of Denmark, to be part of it very closely, and they are evaluating our questionnaires, and we'll have a session with them over the next months, just to try to keep our nose in the track to give to do the best we can over the next 6 months. But we have to develop this, so we have the framework, but they will be able to push it over the next months. So that's the 4 examples.